Well, I just want to make sure that people on Zoom can hear me well. Yeah, I wonder if people on Zoom can hear us. Okay, great. Thanks. And I believe you can see the screen, right? I'm sharing the screen, so you should be able to see the screen. Okay. Great. So let's give maybe 1 more minute for people to join and we'll get started. Yeah, this is our Dr. Chinese, our previous director. So I need someone to help me. Nature. Is Nature here? Okay. I think because people on Zoom, I need to manually join them. I'm not sure if people are getting there. I will ask Ray to be people for this teaching. Let me know. Yeah, sure. Thanks. I think we can get started with our event. So welcome everyone for joining today's poster day for ISL. As you know, the Institute for Social Longevity is a cross-disciplinary center for campus for advancing aging research. So we're really trying to take a multidisciplinary approach and bring people together on this type of event. So very excited to have this event this year. And this year we'll also have an expanded version of this event by having a keynote presentation. So we're coming here to celebrate incredible work done by our faculty, students on aging and longevity research. And this year, we also have opportunity to expand our poster day to include undergraduate students. So we do have undergraduate student presenter here to share their discoveries and engage in meaningful discussions and receive feedback. So students, they do need feedback from colleagues, like experienced researchers like you, so that they know how to advance in their career. And also at our ISL, I want to emphasize that we're really dedicated to bring together experts from different fields to tackle challenges of aging. And this year we're also honored to have our guest, Dr. Zhang from University of Minnesota, to be here. And his expertise in AI-driven health research is really shaping the future of precision health and aging. And also I want to thank our judges. We have Dr. Ravi Nakpo, Dr. Lin Patton, and Dr. Zilong Xie helping us judging the student poster today. So thank them for the wonderful and incredible work. So we're gonna also announce the winner for today's event after the presentation. And also we're gonna have Dr. Jim Clark, our provost, joining us later in the event. So he'll give us his remarks before we head started with our award ceremony. And also, we're gonna head out given the annual scholarship award, the Esther Growth Scholarship to winner. So we're gonna make an announcement today in our award ceremony. So without further ado, let me introduce our guest for today. So our keynote speaker today is Dr. Ray Zhang. Dr. Zhang is a professor and founding chief of Division of Computational Health Sciences at University of Minnesota Medical School. He's a McKnight Presidential Fellow. He holds multiple leadership roles, including co-chair of the AI and Data Science for Healthcare Working Group and scientific co-director of the Innovative Methods and Data Science Program. Dr. Zhang's research focuses on integrating AI with healthcare, analyzing multimodal biomedical data, including electronic health records, biomedical literature, and patient-generated data. As a principal investigator on multiple NIH-funded projects totaling over $20 billion, he has led groundbreaking AI-driven studies in drug repurposing for Alzheimer's disease, breast cancer treatment outcomes, dietary supplement safety, and bias in medical language. His work has been nationally recognized, including honors from AMIA, the American Medical Informatics Association, the Journal of Biomedical Informatics, the coverage in Wall Street Journal and CBS News. He's a leader in biomedical informatics. He recently has been elected as a fellow of American College of Medical Informatics, one of the most prestigious honors in our community. And also he's a fellow of American Medical Informatics Association, and currently also serves as the chair of AMIA's Natural Language Processing Working Group. So let's welcome Dr. Ray for the keynote presentation. Yeah, thanks, Dr. Zhehe's introduction and the invitation to this seminar, and then feel honored to present my recent work, especially AI in a different clinical application to the audiences. So today I'm going to talk about in 3 areas: nutrition, aging, and cancer research. So as you see in biomedical domain, there's a lot of data, including researcher and clinician document clinical electronic health records for patients, including clinical notes, and then they also report their trials information and other research in the biomedical literature. Patients also report their first-hand experience, such as using the drugs in the social media. And then also there's a lot of data for clinical trial, which is clinicaltrial.gov data. While through a proprietary AI algorithm from traditional model to deep learning to most recently large language model, all those information can transfer to more structured way that can digest by healthcare providers and clinical researchers. So this can either convert into actionable items through the clinical decision support, or generate hypotheses for clinical researchers to do the further analysis, or can monitor the safety signals about the drug use through the social media. So the first area, which is a support by NCI, and the other one is the NIHMD, which we really looking for how can we analyze the existing data, mainly the electronic health record data, to monitor and predict the adverse event associated with the cancer treatment. Well, there's a lot of information, specifically personalized the phenotyping document in the EHR data. And then we focus on the breast cancer, which has the second highest death rate in the United States, while the cardiotoxicity has been a really significant problem since associated with the breast cancer treatment. It's around, depending on what kind of treatment, is a range from 7 to 13%. No matter it's target therapy or chemotherapy or radiation therapy, they all lead to different kinds of heart diseases in the future. So the question is, there's an active area, it's called cardio-oncology, which is a team between cardiologists and oncologists to closely monitor the development of heart diseases for cancer treatments. While there's a lot of information, for example, patient personalized phenotypes embedded in the clinical records, specifically like pathology reports and clinical notes. So as you see from the right upper corner, there's a lot of deep information such as the histological type, cancer type, stage, tumor size, laterality. There's 8 different phenotype types that are embedded in the clinical records. But all those information is really a key to do the personalized prediction of their cardiotoxicity. So one of the challenges currently, there's no language model that specifically trained the cancer domain. So we among the first team in the nation to develop a cancer domain specific language model. This is even before the large language model was launched. So we leverage the general domain trend, which is called Bluebird. We also train in general biomedicine, so get some language about in general, language. So they use Mimic and PubMed as pre-training, but they haven't really trained in cancer domain. So we leverage the University of Minnesota healthcare system, including 4.5 million clinical notes and 1.3 million pathology reports. So we pre-train continuous training the Bluebird, and also we manually curated those phenotypes. We got about more than 200 clinical records, and human annotate those information. We did fine tuning, so which we generate cancer bird. So we also leverage we compare the terminology and dictionary in the cancer domain and compare with general domain and the dictionary that in the original bird model, we still found a gap. So for example, HER2 is not within the original list of bird model, while HER2 is the cancer receptor status. So we additional add. So add different dictionary. So we modify their dictionary. We add one is based on the expert suggestion. Another one is based on statistic. And we also compare original. And all three models compared to the state of art in that time, we got better performance. Well, another problem is you generate a model that fine-tune in your local healthcare system. What's the generalizability or portability when you evaluate that in another institution? So we collaborate with Mayo Clinic, which they also have clinical records. We use the same annotation guideline and annotate. So we did evaluation, but also we create a kind of permutation data set, which is we replace some of the University of Minnesota coffers by using Mayo Clinic coffers data. So it's add some noise into our current. So we also did a comparison. So based on our evaluation, as you see, the 9 figures, the first 8 is represent 8 different phenotypes. The last one is overall. And our cancer bird demonstrates more generalizable compared to other machine learning or deep learning models. And further, we use those cancer bird generated cancer phenotypes, so convert those into structured data. And we also leverage other information, which is mainly documented in the structured data, such as vitals, labs, preconditions, medications, treatment, demographics. And then the last one, the phenotypes, is using cancer bird generated. And the outcome is 6 different heart diseases. And then we also create is called LSTM-D, which is considered the missing value across different time. And then as you see the right corner, here's the 6 different phenotypes. And the red bars is using the model without the NLP feature, which is without any information that processed through cancer bird from pathology report or clinical notes. It's only structured data. And blue bars include those NLP features. As you see, all the models with NLP feature addition, the performance increase. And our model, LSTM-D, outperformed the other models across the 6 areas, 6 heart diseases. And we also compare during the length of the data we use to predict the heart risks. So we compare using only 1 month all the way to all the data. We found some disease, the first month data is pretty important. While you add more, definitely you add more information, but really depends on the disease. Some you add more, your computational cost is more, and then but may not really add significant value to that. And currently we are working with the local healthcare system, trying to implement this algorithm to their clinical decision support. So the provider can estimate when the patient has a high risk, they may recommend the patients go back to primary care or maybe monitor with cardiologist. So they may potentially get some cardio prevention medications. So since recently large language model is popular, we also updated our model, which we created called a cancer LLM. So we also use a different open source large language model, since in our university, we do not allow using like ChatGPT, since you essentially sending the data to OpenAI. So we have to use open source large language model. So we download those large language models and we do the pre-training and fine-tuning. So mainly we focus on the two tasks. One is called phenotyping extraction. The other one is diagnosis generation. And also we expand not only the breast cancer, but expand to 17 cancer types. Previously we used Mistral, but right now we use DeepSeek and other open source models. The first phenotyping extraction, we use a similar data, but we convert that into the question answer. So instead of we have annotated, say, this is the cancer type, instead of we feed that data, we just ask, we feed in the pathology report, we ask the question, what's the cancer type of this patient, and using that annotated data as answer. So we reform the original data. So we form that question answering. And our model, which is we choose 7 billion. One of the reasons is we don't really want a really computational expensive model. We try to limit to only 7 billion, but to do comparison, we also compare with a 70 billion. As you see, our result is comparable with the 70 billion model, and our cancer burden is still achieved very comparable. Second task, we mask the diagnosis information in the report. So we only fit the rest information into model and ask them to generate diagnosis. We also leverage their diagnosis code as well as diagnosis text in the reports. So we did a comparison very similar to the phenotypic extraction task. We got a really comparable result with 70 billion. But one of the things, as I mentioned, is efficiency, especially in academic healthcare system. Efficiency is important. As you see, we use probably half time and much less memories for both tasks. And recently, I'm not sure you're familiar with the NIH All of Us research program. It's a historic effort to collect and study data from 1 million people that live in the United States. Right now, they have, I think this is the data from last year. So at last year, they recruited already over 800,000 patients, including an EHR, the biosamples, and also a lot of survey data as well, and Fitbit data as well. So it's really diverse population. So we use the same risk prediction cardiovascular diseases for breast cancer, but we leverage their EHR data and also lifestyle, social determinant health for multimodal risk prediction. This is one of the JAMIA featured articles. And then we use a different category. So the survey data is one of the challenges. So there's many survey questions. We use clustering method to class very relevant question together, and then to do the prediction. So this is the different prediction and CAM curve, and also the significance of variables for cancer prediction. And most recently, we use the Fitbit data to analyze how the physical activity association with chronic diseases, which are already on the archive as well. So second area, sponsored by NIA, is for, you can see. Is for knowledge discovery for aging. As you see, aging, ADRD specific, a chronic disease, and the prevention treatment for ADRD is still a challenging task. And then there's no permanent remedy for ADRD to date. The medications are considered as reduce the pathological progression, but those medications also have a very marginal effect. And recently, we're trying to explore the non-pharmacological interventions such as music therapy, diet, exercise, aromatherapy, and others. offer alternative intervention. This is a graph from National Center for Complementary and Integrative Health. As you see, the CIH approaches, including the nutrition, psychological, and physical interventions. And our focus in this study is explore those areas, their potential intervention effects for ADRD, and how they are synergetic effects with drugs as well. This is a national survey based on the people use CIH approaches, natural products, yoga, Tai Chi, massage, and many others. So this is our overview of this R1 grant is first, we focus on ontology. How do we do the knowledge representation of these non-pharmacological interventions? And using NLP and large language model to extract those data from many biomedical literature. And then integrate with other existing, for example, pathology, chemical property, genomics, and others to form a cardiotoxicity, which is non-pharmacological and pharmacological knowledge graph. And the next step is to how can we do the prediction that is not reported their potentially intervention. So you see the missing dots here is what we are trying to do, link prediction. And then we also test the synergetic effects between the medication and non-medication to the combination. We use a variety of existing data focused on multi-site EHR data. Like this is a collaboration with Yale Huaxi's group. And then also we use clinicaltrial.gov data. Sometimes they also have reported outcomes. And finally, we will select the top ranked PI and non-PI interventions, and we will do the animal models in a pharmacy lab. So first, we did a foundation work since currently there's no CIH terminology representation in the Unified Medical Language System. So we work with nursing faculty who have already manually curated terminology from online resources. We also expanded that by exploring others. And then we found our lexicon also is only matched about 30% with Unified Medical Language System, which is considered the largest platform that incorporating over 200 biomedical terminologies, but there's still a gap there. Secondly, we developed some NLP system that can extract these entities from biomedical literature, leverage the terminologies. Our previous study in the nutrition, I will show later, is using leverage those lexicon, you can get extract more information, which is increase the recall of the information embedded in the literature. So the terminology is really important since that can capture a lot of lexical variations. So we also compare in the EHR, what's the best way to extract such data? So we found the CPT code is not a perfect way since CPT is not specifically. So we have to leverage the notes information. And this study is very simple. We use some keywords that we extract from our lexicon. We found many information also documented in the clinical records. So that is a guide us. We needed both structured and unstructured information to capture the CIH usage in EHR data. And then this is a comparison with some, status, symptom, and frequency of using those. We only focus on a few of them that is commonly used in music therapy, chiropractic, acroprosthesis, and some even rule-based system. We found is not perfect at this stage. So we are continue expand our annotation data and explore large language model in this area. So as I mentioned in the M2, we're trying to leverage the AI that can repurpose or predict the link between the non-pharmacological intervention to ADRD. So we previously developed a nutrition, which is called sub-KG, which is extracted the triples from biomedical literature. We further identify the CIH lexicon, which can further filter based on the current semantic medical database, which is a triple information that is extracted from the literature. And then we use a serious pre-processing and make the graph is not huge, make it more focused and more specific. And we integrate them, we convert one knowledge graph called AD-int, is AD intervention knowledge graph. And we use different link prediction methods, including embedding-based and also deep learning-based. And most recently, we use large language model-based. And we predict what are the top drugs and supplements and CIH approaches that potentially intervene ADRD. And we use a series of evaluation. For example, we use a clinical trial data set. To do that, we assume we only use the data set before the clinicaltrial.gov report. So we only use the previous, the time period to predict later. And then the other one is we use in real world data. So we do some prediction and we do use the patient data to see people use one intervention versus the people don't use, how their ADHD progression. So this is the link prediction comparison with a different algorithm. And we use the most one, which is a GCN deep learning model. And this is a visualization of the different semantic types, including molecular, drugs, disorder. So you can see the Alzheimer's disease is in the red cluster. There are some therapy, as you see here. So it's large graph. It's have over 1 million H's and over 160,000 nodes. So this is the deep dive for what we developed. And for example, we find photochemotherapy that is potentially intervene ADRD, and then you can see the pathway through the immune response. The other one is, it's hard to read, but it's one of the natural product. And then there's two potential pathway through the interleukin 6 and TNF, the protein. And then this is the pathway, and then their corresponding articles reported. For example, the first one, there's inhibits from the two articles to a TNF and interleukin 6, and there's of course is ADRD. And then the left is the top drugs, supplements, and CIH approaches. This is a local evaluation using year-to data, patient using psychotherapy without. And the second one is manual therapy. We do find the differences between the people use and without use. So this is a study from initially create a knowledge graph using large language model to extract from biomedical literature and to the link prediction to the validation. So this is the kind of full pipeline to generate hypothesis. The next step definitely using more EHR data to further narrow down the ranking. And also we will send some CIH approaches for the animal model validation. So we are currently in that stage right now. The most recently, the JBI paper, we leveraged large language pre-trained text embedding. That is a leverage, a lot of information is already in the UMLS that can give the node information, but text description convert into the text embedding. So we found that is leverage that pre-trained text embedding, which is domain knowledge with the GNN model, can get a better performance. This is our comparison. We evaluate generalizability through the two public data and the two knowledge base we created. They all demonstrate the similar consistent outcome. And then this is the two-dimensional testing visualization. So the vanilla RGCA, which we used previously, the lower bottom is a fuse linker we do right now. As you see from the visualization, you can clearly see the clustering is more clear compared to the first one. And then most recently, we collaborate with computer science, human-computer interaction lab, that we trying to build some patient-facing mobile app to leverage the knowledge graph but also reduce the hallucination of large language model. So we leverage RAG and our backend knowledge base, and also this is the front end design for how the step by step using chain of thought, how people think about the questions. This is the one that Oliver mentioned in VIS, which is a top visualization computer science conference. And there's a further design in a different state. And then we also did an evaluation. We used some user. Then the feedback is this tool, non-net, is easy to use without any assistant. And it's also give us a lot of explanation, connection between entities and literature. So as you see on the right panel, there's also literature corresponding each link. And then we also asked them to use GPT-4, and then they said GPT-4 responses are longer, and sometimes they have a lot of redundant information. Why not is using combination of visualization and text, and I can focus on more important factors, and graph is pretty useful. Well, finally, in nutrition, this through almost 10 years support from NCCIH, we are probably around the first group in the nation to develop a lot of informatics resources and tools to support dietary supplements research. So dietary supplements, how many of you use dietary supplements daily or frequently use? I would say 7 to 80%. It's very consistent with national survey. So national survey is 87 to 89% US adult use at least one dietary supplement. Why? How many of you also use drugs at the same time? Yeah. So that is one of the issues that's not always safe, especially use both. Why? The doctors are poorly informed. This is the international survey. Over 1,000 clinicians, 75 of them have really poor understanding about safety, since supplements do not consider as drugs. So FDA regulation is different, but they are not always safe. Can anyone give me an estimation in US annual emergency visit just due to dietary supplement? How many emergency visits?
15 million.
50. Okay, that's a good guess. 10,000, 20, 50,000, 1 million. Yes, 23,000. This is based on CDC and FDA report. It's back in 2015, 10 years ago. I assume they can report a new data. But as I also mentioned, the drug supplements action. So for example, if people take St. John's wort, it's pretty common, but the high performing component in the St. John's wort can reduce the doxycycline mechanism, so they can reduce the efficacy of the drug. Why the documentation is hard. So it's follow the DASHA, Dietary Supplement Health and Education Act 1994. It's different from even the OTC drugs. And OTC drug considered as drugs. While the safety testing FDA approval not required before marketing. And the post-marketing report, they do have that, but it's in the different, they call so drugs has called FAIRs, while those dietary supplement, food, cosmetics is called CARES, it's different. And then the reporting is only required for severe adverse event, for example, hospitalization, disability, and death. So it's very underestimate the risks of using that. Well, there's a lot of resources, actually, online resources, literature contain a lot of PK/PD information, pharmacy exams, and EHR, patient report, their usage of that. So our study is trying to understand, try to develop informatics resources, including terminology and ontology, and also the knowledge bases that can leverage all kinds of resources that talk about safety dietary supplement. But first step, which we did, we created a called Integrated Dietary Supplement Knowledge Base, IDISC. We incorporated the 4 very high quality resources, including dietary supplement labeling data that's curated by NIH. There's also comprehensive databases, and also there's a Canada labeling databases as well. And then this is our central data model. So we use iteration process. We work with domain experts, including clinicians, pharmacists, and clinical researchers, informatician to design this. We decided we use ingredient as a central concept, so the ingredient can link to the products, and the ingredient that actually has a lot of function. For example, it have the interaction with the drugs. It can treat or cause some disease or sign symptom. So that's why we have that information. But also there's also ingredient, they have a lot of scientific names, synonyms, which we captured for, should I click admit? So this is the final statistic we have. We incorporated over 144,000 concepts. There's a lot of relationships, over 700,000 relationships. We also did a manually review, so we captured 10% of them. We compare with the source resources. Is high quality, and so far there's thousands of downloads using those resources. Well, the first study we demonstrate the value of IDIS is we compare with UMLS. We found many of them, half of the IDIS terminology is not represented in the UMLS. So we leverage NLP, we use UMLS and use IDISC. We did name entity recognition. Essentially, is identify the names of dietary supplement in the clinical in the biomedical literature. We found our IDISC can help to increase the recall significantly. And we also leverage, we use that, we create a called a supplement KG, and we use that to identify or discover novel drug and supplements interaction that previously not reported in any literature. So in this study, we use a very simple method. We use some filtering, and we also using designed pathways. So if one drug interact with one gene, while the supplements interact with the same gene, then they have potential interaction. Or drug interact with one gene and supplements interact with another gene, but both genes can affect your biologic function. This is another pathway. So we use this more kind of rule-based design to make it more interpretable. And then we found a lot of drug and supplements interactions. For example, these are listed. And here's identified pathway. And then first one is drug, the dietary supplement to the gene. The second column is gene to the drug. And we also ask the pharmacist and clinician to evaluate the plausibility of those identified potential drug supplement interaction. Those are highly recommended as a plausible interactions. So this will give us a way not only extract that, but also identify some potential ones. And most recently, we also developed an app that can leverage large language model and RAG, and then design the usage that can communicate with users about what is a proper use of dietary supplement. If you use anything, are there any risks, or are there any reported effectiveness? Since there's a lot of marketing of dietary supplement, they say this have efficacy of ADRD or something, but this tool can help you to see, are there any evidence in the literature, yes or no? And also, do you currently use any drugs? If you want to use dietary supplements, are there any potential risk or dietary supplement interactions? In the future, we will incorporate more information from social media and from EHR. We could even share, say, some patient report in their social media their potential effects, or we found in EHR report that patient reported some adverse events. So try to give patients more kind of education material advice more through the QA and large language model ways and visualization as well. This is the one, we compare with GPT-4. This is the different comparison in the 4 different areas. So one is interaction, effectiveness, and then different comparison. So our IDS large language model with RAG is outperformed than GPT model. And this is some demo for questions provider can ask using our tool. The EHR data also contains a lot of dietary supplement usage. So the information we can extract is their use status. Do they currently use, or they stop use, or they don't use it? And also we can extract the relationship. Does this dietary supplement cause some, adverse event, or they trying to use this supplement for relieve certain sign symptom? So all those information is very important, and also the evidence is high since those documents is documented by physicians. They use their knowledge to judge that and document that. So which we convert this into multitask. We need to identify the dietary supplement. We need to identify sign and symptom and classify, differentiate this side effects or this effectiveness. So which is relationship extraction and their use status. So we form this multitask learning project, and we also leverage RAG, the retrieval augmentation generation, which is a new technique, and we use large language model. And we did a lot of comparison using different large language models with the retrieval, and I think we get best performance, I think 90 something for each different tasks. This is a comparison of the different RG models. So around between the best performance at 85%-ish. So this is still ongoing R1. So the next step is to further develop the link prediction model. And we also trying to develop a serious tool we call iDiskMine that can leverage NLP, LLM, and also create an ETL process. We're trying to also external validate through the UT Health. The group was originally Mayo Clinic. They recently moved to UT Health. So do external validation, but also implement the tool in their cohort that we can extract research databases combined together. While we use a lot of Odyssey, which is observational health data science and informatics, which is a nationwide common data model. So we also collaborate with them, trying to extend our tool. So one of the challenges, as I mentioned, dietary supplement terminology is not well represented in the UMLS. While the current CDM, the common data model, they use the UMLS, known as CT, which we have to add additional dietary supplements information in that. So we'll work with them to add that and demonstrate if you enter a new domain and then you found there's a terminology, shortage, how can you add additional that? So we're going to demonstrate locally to see we still can work on that, add additional terminology. Secondly, we will work with NLP working group to say, besides the name entity recognition, we also want to extract, for example, use status, relationship extraction, which is not currently in that NLP platform. How can we demonstrate, add additional features? So the final goal is we can disseminate this tool to more healthcare systems, so we can generate a lot of evidence from multi-site EHR data, and essentially we'll fit into called EDIS, Enhanced Dietary Supplement Knowledge Graph. So leverage the biomedical literature, use more advanced large language model and online resources, multi-site EHR data, social media extract information, and FDA Cares, which is a post-market support system. And we will integrate all of them into a center data model. So this will be more enhanced, comprehensive data, a dietary supplement knowledge graph. And the next step definitely is how can we use that? So for example, can we use that in the clinical decision support to provide better clinical outcome? Can we educate patients to use that? So there's a potential, a lot of downstream products on the road. My expertise is in NLP, a large language model. Certainly, we did a lot of advancement in large language model. So first, Name entity recognition is one of the key tasks in biomedical domain, which is, can you identify drugs? Can you identify sign, symptom, or disease from text? While I leverage the retrieval and chain of thought approaches, we create a framework that can apply to any large language model and improve their performance. So we call it RT. This is the first to combine RAG and chain of thought and achieve the SOTA performance for few short NER. For example, we compare with some other platform with others. We got the best performance. I will skip this into the different outputs options. The second one is relationship extraction. Is to, after you identify those entities, can you identify the relationships between them? There's still one of the challenge tasks. It's very basic NLP domain task. Is one of the Jamia featured paper is we designed the different option combination, instructive tuning, prompt engineering, adaptive prompt, and then we use a different combination to see which kind of combination would be the best, and then see we choose task instruction example option description and a different composition sequence, and then we use the best of them. We also add embedding, which is we consider as a software prompt. We add one embedding before instruction or between instruction and example, or add both. All the three we call leap frameworks can help the original logic animal to get a better performance. Federated learning is popular recently since it's hard to share patient data across different institutions. There's a lot of groups working on using the structured data during federated analysis. Why I consider this as the first biomedical NLP domain using federated learning. While this is not real patient data, we do some simulation here. So we capture 8 different couples covering many name entity recognition and relationship extraction data. And we include popular deep learning model as well as transformers as well as large language models. And then we compare with a centralized model. So centralized model, essentially, you group the data together in a centralized repository. So this is considered as the cap. And then the federated learning is you chunk them into the different, agent. And then you communicate, the model communicated with each agent and update the. So as you see, our model using the FedAVG is really comparable with the centralized model in the different databases. And then this is the performance in our relationship extraction. The yellow ones is using federated learning compared to the dark green ones is centralized model. It's very comparable. Also recently we created called biomedical RAG is for biomedical domain. There's 5 tasks we evaluate our methods that can outperform the other models. We chunk them into a tailored chunk score. We designed a score, and then this is the comparison. Any large language model plus biomedical RAG can improve the original performance. For example, this one, the Llama 2 plus our framework improve the performance. And then this is the other task classification link prediction. We also, for the medical QA, we experiment not only one single LLM is the best. So how can we use a mixture of the expert? So using the vote from multiple large language model can help you to get better performance. Interpretable differential diagnosis. So large language model, one of the advantages is provide the interpretation and reasoning. So we curated a new data set. So currently there's 570 clinical notes that span the 9 specialties, but we only give the differential diagnosis. So based on this test, give the gold standard is the diagnosis A versus B, but they didn't give the reasoning. So we invited the domain expert to also provide the reasoning why they think is diagnosis A and B. And then we designed a large language model called dual inferences, is from the symptom to the diagnosis, but we also backward inference it to make sure it makes sense. So through an iteration process, we meet a certain criteria. And then our performance compare with other chain of thought and other get better performance, as you see the red bars. And this is the performance comparison of diagnosis as well as reasoning. This is published in the MPJ journals. Finally, I want to introduce our division. So it's essentially computer science plus health, so computational health sciences. So it's established in July, about 3 years ago, and then it's an interdisciplinary academic unit in the medical school, where the faculty training student domain expert from diverse, including data science, AI, computing, statistics, epi, and implementation science. We try to develop and provide novel insight toward optimizing health and patient outcome by developing and implement novel computational tools, including machine learning, NLP, CV, predictive modeling, human computing action, omics-based data, knowledge representation, and other. Our Blue Ridge ranking, this is based on NIH funding. This year, we're in the Department of Surgery, we are number 4. So this year we got over almost $23 million. Last year we also the number 4. And the public school, we are the number 11 public medical school this year, nearly 300 million NIH funding. Last year was number 9. So those are current faculty member. As you see, faculty member from human computing action, interoperability, implementation science, bioinformatics, computer vision, and trustworthy AI. And we cover a lot of methodology areas and also clinical domains. So this is a really wide spread of clinical domain, including cancer, AIDS, and mental health, critical care, obesity, nutrition, drug safety areas. Currently, our division faculty have active grant nearly 70 million total cost. So not only NIH, but also CDC, VA, ARC, and a lot of industry grant like Cisco, Medtronic, since the harbor is in Minnesota, Amazon as well. Besides the talk I gave, I also have some interesting, for example, VA, we developed some tool that extracts the social behavior from veterans, and that can help to predict the suicide in VA, since suicide is the #1 priority in VA data. But their environment is different from our data, so some tool you cannot use, so you have to adapt what is available there, what it can do there. The CDC one is very interesting, since this one is to leverage the entire Minnesota. There are 13 healthcare systems, cover over 90% Minnesota residency. But think about the pandemic COVID-19, the CDC announced initial 4 symptoms and later 11, but it got really delayed. So one of the reasons for that is they don't really access EHR data that can monitor what are those cases, the symptom differences. So this one we will leverage 13 healthcare systems. We will implement NLP system to access their data. So for the next pandemic, we can prepare, say, those are list of symptoms we can extract for those next pandemic disease and versus the other. So we can give more quicker suggestion to CDC to publish a symptom and symptom list. I think I will stop here, and then thank you everyone, and any questions?
I don't know Dr. Zhang when I was a student at New Jersey. Actually, we got to know each other really well along the years, and now we're all both full professors. So I think for students, it's really an incredible opportunity to be able to know Dr. Zhang's work. And as you can see, there's a lot of work, currently speaking on one project, with a few others. So it's definitely amazing work. So please, ask questions if you have any questions about nutrition. Because I know many of our students are from nutrition health and sciences. please feel free. And also I have questions online, so we can also open your mic. And I have a few questions.
Great presentation. I just have a quick question. I know when developing like an LLM for medicine and clinical reasons, I know it's recall is way more important than precision because I'd rather be like think of your cancer LLM. I'd rather be told that I have cancer when I actually don't than the LLM to miss my diagnosis. So I think recall is a little bit more important in compared to precision. What goes into improving something like cancer LLM or any of these models in recall specifically? Is it feature engineering? Is it like how do you go on in improving that, you think? Or maybe it's training?
Yeah, that's a great question. I agree. Like you don't really want to miss any, it's false negative, right? You try to reduce the false negative. Yeah. So I think that still, through the fine tuning the stage, you can, make some manage metrics as your, criteria priority, and then can, continuously improve the performance. But yeah, I think that's a good question since typically right now people report more like F1 as they are more, gold standard as the major. But I think the point is, yeah, it's great. And then recently we also we call it selective learning, which is, LLM is not maybe good for some, it's perfect performance for a small cohort, but not good for others. So selective learning is we're 100% sure for those cohorts. So the physician don't even take a look at that. Well, for some cohort, we are not certain this, we need more attention for, provider. So this can save a lot of, energy and cost for operation. So I think for, learning healthcare system for future implementation, there will be a lot of consideration talking with provider. What will be the most important, as you mentioned, like the recall is more important in precision. So I think that, getting the, imports from provider will be really important.
Hi, thank you for your presentation. My question is about specialists in healthcare and how many times we see doctors who are not in the same practice who are all giving us results that might be related to one another, but their electronic health records are not linked. So in a decision making and care guidance setting, how do you link together information across the same patient that might be in 6 different practices?
Mm-hmm. So can you give me an example, like what kind of practices? You mean the specialties? Yeah.
And they're all in some ways interested in your cardiovascular health, for example, but their records don't speak to each other because they're in different practices. So how can they make a more informed care plan for somebody?
Yeah.
Using the tools
Yeah. That's a great question. So typically that's our healthcare system using Epic. So all those specialties, nodes or records are in one place. So when we develop those, we incorporate all those specialties information, but put it into temporal way, longitudinal way. So we don't really differentiate what specialty we should focus. We leverage all the information together.
Yeah, I guess it's different from different settings. For example, in Tallahassee, we do have a lot of patients like what Nikki mentioned, is you go to your primary care and then refer you to different specialists, and they use different systems for capturing your medical information, so they don't, get to talk to each other. So that's why actually we have opportunity here for this setting to create some sort of tool to capture those data for individuals.
Well, and one doctor might order labs, but then it only goes to one of your medical records and not the other 3. But it might be relevant to all of them.
Yeah. So I think this is really the EHR consortium I mentioned, across 13. So I go to one hospital and transfer to another one. The doctor always see my record from another hospital. And then the EHR consortium, right now we convert all the structure into AMA. So you actually can access all the Minnesota healthcare system, the structured data, but right now we are working on implement NLP tools.
Few questions on dietary supplements and problems with trying to study the supplements. One is that you mentioned social media and how reliable are those data, and do you assign different priorities for say what's coming information from the clinical offices? And you might have touched on that for a second, but maybe not. So do you prioritize your information?
Yeah. So yeah, we also got the same comment from study panel, United States panel, the data quality. Yeah, we realized the reliability for patient self-reported definitely is lower than EHR or biomedical literature. So what we do is we only extract the information report, but also we will tell them this information from social media. So the end user, I mean, for all of them, which is a prevalence, we tell them this is from literature, and we give their original sentence and article. For EHR, we may not share the direct information of EHR, but we'll tell them this is from EHR data and the social media data. So the users may, based on their, use cases, they may not choose, the data from social media. They only choose the data from literature or EHR data. There's a different reliability and also the time lag. So since social media, the time lag is lower, since they can report immediately, and then they go to the hospital, EHR a little bit later. But for some other like literature is way behind, since they will do a lot of. So there's a different time period. We did one study like using those data. We can do some signal detection. Based on adverse event, we can predict potentially this is from this dietary supplement and later some reports. But yeah, to summarize, I think what we do is we tell them, clarify the resources from social media instead of others.
And if you consider trying to figure out what part of the adverse events or the actual positive effects are due to the placebo effect, a lot of that is in dietary supplements, but even drugs have a placebo effect. Is there any way to sort that out?
From social media data?
Well, yeah, from those data.
That is a great question. So right now we only focus on information extraction. But right now we don't really have approach to see is this, this the true fact from this or like placebo. I'm not sure this is your question. Yeah. Right now we don't have solution for that.
Related to that, is there a way to get at adherence to medication based on the actual outcomes?
Adherence?
Yeah.
Yeah.
Maybe like actually.
So the use status, the model we developed is actually monitor how often they use, do they continue to use. So we check each individual data points when they report, we check the status. And then we summarize their status usage adherence. I think there are other acting groups in the nation, they specifically focus on the drug adherence, which is a very significant problem associated with outcomes.
I think we can leave some questions offline. Dr. Zhang will still be around for our poster presentation today. So I have about an hour and 50 minutes for the poster presentation, and my strategist will be kind of walking around and giving you some comments on the poster and also the technology. Just proceed with the poster presentation. And please come back, 10 or something like that, when Dr. Jing is here, you can come back to the. And also we're having food out there, so we can just grab something. Enjoy the presentation. Thank you again for it. Thank you. Thank you much for everyone.